Return to play after anterior cruciate ligament reconstructions. When and what tests to do? Safe or sorry? This is the status of where we are in 2016. I'm Mary Lloyd, Ireland. That's my website if you're interested in this or other presentations or updates. I'm an orthopedic surgeon, work at the University of Kentucky, Department of Orthopaedic Surgery and Sports Medicine. Disclaimer side, I nor any family member have any disclosures. The functional assessment tests that are done are a basic versus an advanced. This is like a level 1 versus level 2. At the University of Kentucky, these are the things that we do. We're assessing strength with leg press, balance with a couple of different ways, timed agilities, sport-specific dry land testing to show the athlete level of readiness to return to the field of competition. When you do certain sport-based movement patterns, the athlete can figure out they're not ready to go back, whether it's dribbling with a soccer ball, changing directions, landing from jumping, such as in basketball. And I think it's also important to have the coach or the parents watch them do some of these activities, and they can easily see that they can't really do this in a fast speed game situation yet. They need to continue to work on confidence and improvement. What are the tests done to determine readiness for return to play? The level 1 tests are gait assessment, single leg step and hold times 10, Y balance, strength testing, knee extension, isometric 90 degrees to 0, hip abduction and seated external rotation, one leg at bridge to fatigue, and plank. The grading scale, 3 is normal, 2 equals minimal deviation, 1 equals moderate deviation, 0 equals marked deviation. The assessment is done. They have to pass all phases, and if they didn't pass the phases, it's due to one of the deficiencies such as pain, decreased eccentric knee control, neuromuscular strength, proximal strength. Level 2 functional assessment return to play, hop testing in inches, vertical hop, single leg, broad jump, timed 6 millimeter hop, single leg triple jump, single leg crossover jump, hop testing quality assessment. The grading is similar, good control, sufficient knee flexion to avoid valgus. So I have to land in a safe position, good hip over knee over ankle position, and no valgus at the knee or internal rotation adduction of the hip. So you can see these are more violent movement patterns, more vigorous movement patterns, and are getting close to what they would do at the time of return to their sport. So level to clearance for sports, drop off box to squat jump, plyometrics, repeat this 3 to 5 times. It's graded on 0 to 3. The 3 grade are symmetrical landing on both feet, symmetrical hip and knee flexion. Greater hip and knee flexion, the better, the more control. Landing is soft, avoid valgus at the knee, and landing is balance. If the landing's balanced and soft and symmetrical, then they're on their way back to sports. These are the sheets that we use at University of Kentucky. This is given back to the clinician by the physical therapist or athletic trainer, and this gives us information. Passes all phase, did not pass all phases because of the following, and this will give us a percentage or a number that we can discuss with the patient, parents, and the coaches of what they need to do to pass. And then this would be repeated in another month. Functional assessment level 2, you can see is a little bit more vigorous, more movement patterns, closer to return to sport. And again, it gives a number, hop testing, hop quality assessment, drop-off box. So there are some numbers that are objectives, but some of these other ones, the hop testing quality assessment, are more subjective and are graded by the physical therapist or the athletic trainer. But again, giving the athlete a score, The total goal is a score of 14 out of 15. This is an example of an advanced functional assessment. I really like it when the therapist write the numbers down and we can get, again, numbers. So this is based on a 21% difference up at the top. Single leg long jump is 8%, single leg triple jump 11%. So this gives me information to show the patient, and they're usually not ready at a 20% difference. They should work more on these numbers, single leg vertical jump, and we'll have them work on these and repeat the test in another month. The rest of this, single leg timed agilities, a little bit deficits. The sport-specific agility test, they have 3 trials. This is run and stop, cones, cut, so you can change these based on their sport. And the overall differences in this were 16%. So I really like it when I get an assessment from the physical therapist. So you have 13% deficit quality of movements, 11 overall. So the patient did really pretty well, but they had some things they needed to work on lateral direction changes and overall strength and power. And so this gives the athlete a game plan of when they can really get back on the field and gives them some specific things to work on. The athlete can tell when they're ready to go back. So some of these quality of movements and some of these changing of direction, that's a harder thing to get back, and so they know what they have to work on to be ready, and they will totally ace it the next time. So I'd repeat this in 2 to 4 weeks and see how they do. It's good to have the parents watch them when they're doing this because they can see that they're not ready to cut and be 100%. This individual had normal knees, or this was her normal landing pattern. She was told to hit the tape. So you can see here where she has all kinds of deductions and has very poor control in a normal. So it can be very simple. So figure out which of these. This is the crossover hop test, and she flunks, but this is her normal. She should not be out playing basketball or doing jumping change in direction, or she will have some type of bad knee event. See how she strategizes to try to use her hands a little bit, but her trunk's all over the place. And she really is a very bad lander. Increased valgus at the knee, hip internal rotation, adduction. Can this be retrained? It can certainly be made to look better with balance and hip core strengthening. Proprioception program. This individual had a right ACL reconstruction done. You can see here where he's doing this modified Haydn board just with tape. Look how he drops his right pelvis. His knee isn't as flexed as the left. So dynamically, he's dropping his pelvis because he has hip external rotation abduction weakness. And to compensate for that, his trunk leans. He doesn't flex as much as his right hip and his knee. And then you can see the normal movement pattern on the left, which is a much more trunk over hip, hip over knee position. So an interesting dynamic Trendelenburg, if you will. This is another test. Their feet are on the ground, so you can do this in your functional assessments. They're not going to re-injure their ACL because their feet are on the ground. And then you can look at them, sometime with monitors on their bony prominences, but just eyeballing it, you can tell a big difference. Best test to do to predict return to play safely. This is controversial, so you should talk to your rehab group. Is it the triple jump, the vertical jump, cuts, Y balance? Certainly we think the vertical jump is a good one because we can measure that. We can measure improvement. The Y balance, where you come back to the opposite side, has been shown to correlate with hip and core. Doing cutting in the lab is a good thing to do because they're going to be cutting on the field. And triple jump for sticking the landings. So these are all good tests. Don Shelbourne, who has done many ACL reconstructions over his career, from Indianapolis, Indiana, a new inductee into the AOSSM Hall of Fame in 2016, is well known for early return to play. I asked him about what he thinks about this early return to play, which he is really credited as starting. His response will follow, but his points he makes are very important. You have to learn from your own results. You have to get your own data collection. And you have to know your own results. You can't necessarily compare it to somebody else. Each individual is variable. We can't go by the months of return to play. We go by when they're ready to return to play, which can be 1 or 2 years or perhaps never. I think the message that Don Shelbourne gives us here is a very important one.
It's concerning I know this debate is concerning when we feel comfortable allowing patients to go back to sports after ACL surgery. It's not about a fast versus slow return to sports. It's about getting follow-up on your patients and looking at your own data. I can't tell you what results you have with your patients, but I can tell you what my results are with my surgery and our rehabilitation. First, we have to establish that our patients have reliably been able to get their full range of motion back and have a stable knee from your procedure and your graft choice. If you haven't objectively measured that your patients have a stable knee after surgery, then you don't know if a subsequent instability that occurs with return to sports is due to a failure of graft incorporation or a re-tear of an established successful graft. A purposeful delay of return to sports won't change the fact that the knee was never stabilized with surgery. It just makes us feel better if the patients don't experience instability until later after surgery. Although the average time to return to sports with my patients has been around 5 to 6 months, the range has been from 2 to 18 months. And the time of return was not a factor for graft tear. You have to know the data with your own results, with your graft choice, and then individualize your philosophy for return to sports based on your own data.
How is it best to get the quadriceps back after ACL reconstruction? The leg on the left, patient has patellofemoral instability, miserable malalignment syndrome, and basically our quads are very weak overall. If you look at the male football player on the right, he has overdeveloped muscles, if you will. He had an extra-articular ACL reconstruction, and he certainly is muscle dominant. The ligament dominant individual, like the one on the left, is more likely to tear her ACL. The quadriceps tend to not want to come back after ACL reconstructions, whether we use a bone patellar tendon or a hamstring. We do need to do some form of eccentric or muscle lengthening, strengthening. Open chain can be started in an arc that doesn't stress the graft, perhaps at a couple of months after surgery, from 90 to 30. However, instead of doing open chain eccentric machines, there are safe variations of eccentric quad activities. Total gym with bands early on. Later, use higher weights. Doing squats with wedges behind the heel to elevate the heel. We've got to come up with better ways to get the quad back earlier to avoid patellar tendonitis and improve strength and earlier normal function in running. Eccentric quad. This can be done safely, relatively early after an ACL reconstruction, maybe at about 2 or 3 months. Step up with a dumbbell, step up without the dumbbell. You can adjust the height. I find lunges cause patellar tendonitis, and some of the step downs may not be the best thing. Doing mini squats, single leg with a wedge behind the heel, that'll give an eccentric quad contraction. Doing them with both legs is shown on the right. So these are variations to get eccentric quad activity. Eccentric quad activity, this shows the band on the upper left. There are many different types of hip core with bands, machines hooked to the walls, and then also doing weights. Not this much weight right at first, but this is a good way to get eccentric without doing open chain totally, but do closed chain. So I think these are important things to talk about and implement these as early as you feel comfortable. Use of Alter G, when to start this post-ACL reconstruction? Probably start it when the wounds are healed. Go ahead and start normalizing gait, taking the weight off. So I think Alter G, the anti-gravity treadmill, is a good thing to start early on, and if you have that available, I would suggest you utilize that. Fear of re-injury. The Kineosiophobia scales, I think, are very important to use. We can do them pre-op, post-op. Fear of re-injury is something that you really have to talk to the patient about, not let the parent answer the question, but look in his or her eyes, and you can tell if they're scared. If they're scared they're going to get re-injured, don't let them get out and play in a game. The speed you play in a game is 100%. They don't think about if their knee's going to be re-injured, and unfortunately oftentimes they will be injured. Again, if they're fearful they're going to be re-injured. It may not be their knee that was operated on, but it'll be something. Confidence and getting over fear is very important before returning to game activities. Single leg squat test is simple, gives clinicians information on neuromuscular control. The plank test measures lumbar and pelvic control in side or sagittal plane, and you can see excessive lumbar lordosis. Observe in a fatigued and non-fatigued state. This is work in a chapter by Noyes and Barbara Weston that we wrote the chapter on gender differences in core and lower extremity function during single leg squat. What I've observed over the years, the mechanism of injury, we have two different landing patterns. One shown on the left is the position of safety. The one shown on the right is the position of no return. So muscle activity is improved biomechanically if the knee is more flexed and the hip is more flexed. So the position of safety, as shown here, is with the back straight, knee flexed, hip flexed, which allows our hamstrings or our good muscles to keep the tibia back. The tibia is straight, and control is by landing on both feet. The out of control position, the body momentum's going forward. The trunk is out of control, usually forward and to the opposite side. The hip is an adduction, internal rotation. Hip is less flexed, knee is less flexed, resulting in valgus at the knee. The tibia is externally rotated, the foot is pronated, and the ACL tears in this position of no return. Prevention programs try to get us to land in the position of safety and avoid this position of no return. This is a male on the left and a female on the right doing a mini squat maneuver. You can see here where up on this step, which is easy to do in your offices, just doing a little mini squat. These individuals have normal knees, but you can see a difference in the pelvis. See the female on the right, her pelvis is dropped, indicating a relative hip abduction weakness on the right, or a standing Trendelenburg. And when she is then internally rotated on her right hip, which is internally rotated adducted, there is resultant knee valgus. And to remain upright, her tibia goes into external rotation and her foot pronates, as opposed to the male on the left where he's completely straight. When we look at the side view, the position of safety, the back is in neutral, hip is in neutral. Position of no return, there is lordosis of the lumbar spine. The pelvis is anteriorly rotated, which drives the hip into internal rotation, adduction. The knee hyperextends, the tibia externally rotates. This shows this side view, again normal individuals. Just instructed to do a mini squat. You can see the female on the right has excessive lumbar lordosis, pelvis is anteriorly rotated, knee is more flexed. You can sense that the body weight is forward. So what we test: trunk control, side plank test, knee control, repeated step downs to assess frontal and sagittal plane control, knee strength, isometric quadriceps strength. Through these functional tests, we aim to better quantify assessments of neuromuscular control. that we feel may predispose someone to a subsequent injury. In our lab at the University of Kentucky, Brian Noehren has done some excellent work. I've had the privilege of working with him and asking basic questions back to him, and he tries to take it back to the lab, doing strength tests, whether it's dynamometry testing as shown in the middle, or our markers in the Gait lab. This gives us much information and some concern for when we say you can go back and play at 4 to 6 months and we put them on a treadmill and they're not looking so good. This is a single leg mini squat, normal individual. So when we reach fatigue, he will start doing a little bit of wobbling. So this is the side view, the sagittal view. You can see here where he's getting his trunk a little bit forward. And now he's fatigued, so he doesn't have the control that he had when he first started out. And see what happens, his hip goes into internal rotation, adduction. He's told to put his foot down on the ground. If it doesn't touch or if he hits too hard, then that is a test that doesn't count as that mini squat. So doing some of these maneuvers, again, this is the good. And he gets a little bit fatigued, so he's got good control here, good hip over knee over ankle position. And then here on the side view, you can see where his pelvis is changing in anterior posterior direction, and then he ends up with this position of no return. How many mini squats can we do in 60 seconds? In this study, there were significantly different numbers. When we looked at our ACL side, 60 seconds, almost 32. The normal side was 36, but if we look at a normal control, it's 40. So the question here is the normal side normal, or do we need to be looking at the normal control? So simple thing to do, again, gives us an objective measurement, something simple that we can do in therapy with our patients. So ACL side 32, normal 36. These were statistically significantly different. This individual is 10 months post right ACL reconstruction. You can see here with the pelvis overimposed on her pelvis is anteriorly rotated. She's flexing less at her hip and her knee on the involved right side. And again, when you look here, there's a positive Trendelenburg. She lands and her left hip drops. So when she lands on her left, stays up, lands on her right, boom, goes down. So she has hip abduction weakness, gluteus medius weakness on the right. This is 10 months after surgery. Knee stable, return to play was authorized. But look, she's not ready. If she is doing jumping, running, cutting activities, playing soccer on a knee that doesn't move like the other knee, increased risk of knee problems, arthritis. At 10 months following ACL reconstruction, this individual shown in graphic form, her involved right side, her average knee flexion was 50. On the left, the normal side was 58, and the normal is actually 45 degrees. So less knee flexion on the involved side and more knee flexion on the non-involved side. At 10 months post-op, showing in graphic form her hip adduction, the injured side is shown on the left-hand side. The normal is 16 degrees. In her injured side, adduction was 23 degrees on the involved right side and 12 degrees on the uninvolved left side. So an 11-degree difference in hip adduction, greater hip adduction, again, which places the knee in more valgus. This patient is 7 months after right ACL reconstruction, soccer athlete. She was cleared by her orthopedist clinically with a stable knee, go back and play. We did a functional assessment and a gait analysis, and as you watch her running, again, she's cleared for full soccer, but what is evident is her right knee doesn't flex as much as her uninvolved left knee. She has forward trunk and pelvic tilt. She has a positive Trendelenburg when she hits on her right, boom, you can see the fall that occurs. So this is a dynamic Trendelenburg due to weakness of her hip abductors and external rotators. Lands on her left, she stays pretty level. Her pelvis here is anteriorly rotated, so she's already in a forward position, falling forward, so to speak. There's also a little less hip flexion and a difference in hip adduction. When we drill all this down, looking at the angles, there are differences when we look at our knee flexion angle and also our hip adduction angle that were significant. So again, left side, she's pretty level. Hits on her right, involved side, see how her pelvis drops. So this puts her in a position of no return, which is what we want to avoid when we return to sports, to reduce the risk of re-injury to either leg, particularly the involved side. So clearly not normal gait analysis or running analysis on this treadmill. It's pretty shocking when we clear somebody in the office with a great range of motion and stable knee, quad tone looks good, and then you look at their gait. Pretty shocking. Not ready to return to run or certainly return to competitive soccer games. So 7 months, abnormal gait and also knee range of motion. Her right flexion range of motion was 40, average is 58, normal is 45. The side opposite, the normal side, was 58 degrees in her knee, 40 degrees, so a difference of 18 degrees knee flexion involved compared to non-involved. If we look at her hip adduction, there is less hip adduction on the involved side, 15 degrees compared to 18, and the normal is 16 degrees. When we look at return to play parameters, we must look at several different things, and these unfortunately are hard to measure. It's not as simple as an isokinetic strength test. It's movement patterns. We have to analyze gait, balance, and strength. And what do we compare the post-ACL side to? Do we compare it to their normal opposite side or uninjured side? Do we compare it to normal controls? Some research coming out of the University of Kentucky lab says there's a significant difference in the uninjured leg compared to normals. So perhaps we should be comparing to a normal control as opposed to the uninjured leg. And what are these objective measurements of? Trunk, balance, gait. We need to get objective measurements and give patients numbers so they can tell if they pass or fail. What do the functional tests really tell us? The patient gets it. They get it if they're ready to run and cut and change direction. So the patient really can tell if they're ready to play or not by doing these control tests in rehab, and this gives them an idea of whether they're ready to play or not. It's good to have the coach or the parents watch them do some of these functional tests. I've never seen anyone re-tear their ACL or injure their other knee when they're doing these tests. So this is controlled activity that is like what they'll be doing when they get back to their sport of soccer, basketball, or other sports. So what are the best tests to do? This is a trunk control test. You can see here where there is an ACL side. It's on the right, but she has problems with both legs. So her command is to put her foot down and keep her balance. And basically what we measure is how many times she loses her balance or she puts her foot down. And in this study, the ACL injured side, there were test arrows of 7.1. The control was 3.4. And the opposite knee, or the uninjured knee, was 5.8. So you can see that test arrow was much greater in the opposite non-injured leg compared to controls. So this is one of the studies that suggests that we should be measuring to a matched control as opposed to the opposite leg, because the opposite leg may indeed not be quote-unquote normal. And this was statistically significant at the p equals 0.001 level. Intervention approach, what we must emphasize is hip abduction and external rotation. Stay out of that position of the hip being an internal rotation and adduction. So it starts up at the top. Also, we must look at the back, proper body position with no lordosis of the back, the pelvis being in a neutral position. and this must be integrated with the core musculature to functional activities. So it's a group of muscles that we train them with, but then we need to turn that into movement patterns and assess whether these are safe movement patterns or risky movement patterns. And this can all be learned with repetition. Feedback in some way, perhaps feedback with mirrors. You can videotape these individuals and watch them, put a normal beside them, or have them look at their opposite side. These are the functional assessments. This is a triple jump. So you can do a triple jump on one side of the tape as she's doing. And this is a subjective grading of how well she is able to stop at that third jump and how well she is able to control her balance. So you can see she does pretty well, but she does lose it. She doesn't stick that last landing. So these tests are a battery of tests to talk with your rehab team about what is best and what the athletes fear doing. So that's where they should work on doing these tests in the rehab facility, because they're not going to hurt themselves. But if we let them go out and they do this in an out of control manner and land awkwardly in that return of the position of no return, then they're going to have problems. Doing strengthening with different functioning testing materials such as the TRX. This is a trainer that does a lot of hip and core. You can do a lot of different things with it, and again, you can do things safely. Most of these are closed chain, and this, if you haven't tried it, is a very hard device to use. It can be used at home, and it's a good device, again, more just pulleys and ropes, which is what we've gone back to, more than heavy lifting, heavy weight equipment. So pulleys and ropes. So these are some of these functional tests that you can do, and you can train people to have their pelvis in that neutral position, make sure their hip is over their knee, over their ankle, and there's no rotation in the lower extremity. This is the Y balance. We've done some studies that really show that this is a pretty good test. Again, it gives the individual numbers. So there are 3 different directions. They can go forward, and we measure how far they are able to move the block. They can go in the backward opposite side and same side. So here's the same side. And then they go back in the opposite side. This one is a little more difficult, so this would be a good one to do by itself as well. And you test one compared to the other, but it gives them numbers. Again, you can train on this, and this is more to assess balance and also to give them a training tool where they can see if they do better. Athletes always want to be measured and do better, and so we should make it a game for them in the training room rehab facility. Vertical jump is another good one. When we look at our prevention programs, we don't want to say it's going to prevent all knee injuries. We want to say it's going to improve performance. And by improvement of performance, this can be done by increasing their vertical jump. You can really sell this to volleyball coaches. So you can see where we get her to land in a safe position, jump straight as an arrow, light as a feather landing, and try to jump higher. So she's getting a number of how high she is jumping. Single leg balance catch. So this is something where we're doing some perturbation type things. We're having him think about catching the ball, trying to control standing on one side. You can see where his pelvis, he's got a nice hike up to the pelvis that's off the side, off the foam, so that indicates that he's got good hip abductor external rotation strength and balance. So you can see how he's really working it with his foot to remain balanced. And you can change the throw where you're throwing it where they might not expect and see how well balanced. So a lot of these things you can work with your rehab team and see what works best in your hands. And this can be graded on a timed thing, or it can also be graded on how good his performance seems to be, i.e. if he loses his balance, falls off the foam, then that would be a lower number in the grade. Thank you for your attention. This is a .com where there are more presentations. Protect our female athletes.